Moynihan Lecture for the Royal College of Surgeons of England, which is always presented at ASGBI, is an opportunity to allow someone who's had a sustained track record of innovation and excellence in surgery. Professor Norman Williams is, as I'm sure you know, a professor at Barts in London and has been for some considerable time. He's had a busy clinical practice, but he's also been very innovative. He's been a leader in British surgical research. He's been a president of SARS, and he's been a major leader of the Royal College of Surgeons of England research initiatives over the last few years, which has led to a huge amount of improvement in funding for research, and indeed has changed the pattern of research across the UK. So it's my great pleasure to invite Norman to give this Moynihan Lecture. It's entitled Attempts to Innovate in Colorectal Surgery and Lessons Learned, and we're looking forward to what you have to say, Norman.
Thank you. Mr. Vice President, ladies and gentlemen, it's a particular honor for me to give the Moynihan Lecture. Moynihan was a great innovator. He was a great professor of surgery, and here he is in all his splendor. And we're not winning today. Could somebody assist me, please? All right, it's okay. We've got it going, I think, now. Thank you. So he's a great hero of mine. Some of this was born by the fact that I did part of my training in Leeds, like various people in this room, including the present president of the ASGBI and the previous president of the ASGBI. I respected him enormously, and I can't understand why the slides keep going back instead of forward. Let's try again. I keep pressing the mouse, but it doesn't seem to function properly. Is it just the left-hand button? Okay. I've always had problems with my left and right. A great hero of mine, and that's why when I became president of the Royal College of Surgeons, as you can see, I ensured that Lord Moynihan was watching over me. He was an innovator. He established, of course, the ASGBI. He established the British Journal of Surgery. He was renowned both in this country and all over the world. One of the famous stories, just to show how influential he was that he had the train between Leeds and London would wait for his private carriage to be put on the end of the train when he came down to London to go to the college. I thought that was wonderful, and when I was in Leeds, I always hoped they'd do that for me, but it never happened. So to come to my topic, I've got to the stage in my career where I want to give something back to particularly the younger people in the audience. I've tried to innovate in colorectal surgery, but there are lessons here for anyone in surgery who wants to innovate. I'll explain a bit about my motivation and, very importantly, the application of science to some of the innovations that we do. And as I say, the lessons learned. So what was my motivation? I always wanted to be a doctor, but I think it's my relationship with my uncle, who was a fantastic man, loved to hunt and shoot. And that's me, believe it or not, aged 8. Or was it 10? I can't remember, but anyway. And I didn't realize, but several years before that picture was taken, he had undergone an abdominoperineal excision for rectal cancer. And when he heard that I wanted to be a doctor, he took me to one side and said, "Norman, if you're going to do anything in life, get rid of this abomination." You would have never have known, nobody knew he had a colostomy apart from his wife. And at that time, this was the prevalent sort of view about patients who had stomas. The great majority of patients who've had a colostomy for more than 6 months suffer no inconvenience at all from it. They're able to travel, hunt, shoot, and play golf just as other people do. Well, my uncle hated this. He did hunt and shoot, and he did play a bit of golf, but he absolutely hated it. Another motivation to get into colorectal surgery was a quote from Thomas Carlyle. "Thought is secreted by the brain, but poetry and religion are a product of the intestine." I love that quote. At that time, of course, 80% of patients with rectal cancer had a permanent stoma, and how the world has changed. And this piece of work by Bill Heald, of course, and I don't need to go into this in detail, but total mesorectal excision has been the quintessential change in practice. And when Bill produced his first paper, he showed that there was a 4% recurrence rate, less than 4% actually, but nobody believed him actually, although we did. Now, Bill had done the experiment, as Hunter had said to his son-in-law, Edward Jenner. He said, you know, but why not try the experiment? That's exactly what Bill Heald did. But I'm very proud that our group in Leeds at the particular time backed up some of this, backed up and gave the science, if you like, to TME. It wasn't just us, of course. There are other groups around the world also who did that. But we were beavering away, looking at the pathological and physiological aspects of ultra-low resection. So we looked at the 5 centimetre rule, showed you could shorten this. We looked at circumferential spread, which is so important, and showed that if you leave microscopic extensions, that you are likely to get local recurrence, and that was so important for removing all of the mesorectum. And we showed also that if you take out the whole rectum and do a coloanal anastomosis, amazingly, you could still retain the physiological reflexes necessary for continence, which is quite extraordinary when you think about it. And we didn't really understand why. We had theories about that. We thought that there were receptors probably in the pelvic floor, as well as in the rectal wall, that would initiate this. And it's only become recent knowledge, relatively, that we were right. We were right. There are these mechanoreceptors that are not just in the rectal wall, iglees as it were, that are present both in the rectal wall and the pelvic musculature, which are responsible for these very important reflexes for continence. And so we've come to 2013, and in the last 30 years, because of total mesorectal excision, because of stapling, we've reduced the incidence of permanent stomas from 80 to 30%. I think that's a remarkable achievement for surgery. I really do. And it's transformed the whole system. Patients coming in now do not expect, in the main, to have a stoma. However, the question I've asked is, can we reduce the number of permanent stomas even further by technical development, particularly now, of course, we're in a new era of laparoscopy. We all know that there are significant limitations to sphincter-saving resection. I don't need to tell this audience of that. And this is particularly marked in laparoscopic surgery, where the confines of the pelvis at times are very narrow, and it's extremely difficult to cross-staple the distal rectum laparoscopically and get a safe cross-stapling situation. And then there are, of course, variations in anatomy, particularly between the male and the female pelvis. The male pelvis, of course, is a lot narrower than the female and is a lot more difficult to negotiate. So the question arises, why in certain patients can you not access the distal third of the rectum to produce a safe anastomosis transabdominally? And it varies from patient to patient, from BMI, from sex, etc. And I've come up with this sort of context of the rectal no man's land. You'll note my name is Norman, and I think that's a very appropriate term, rectal no man's land. And what is the rectal no man's land? Well, it's that area, that part of the distal rectum. It will vary significantly depending on the patient's habitus, but it's from the junction of the superior border of the levator ani to the superior border of the external sphincter. It's that area that you can't always access from above, and as I say, it will vary. And actually, this area, depending again on the habitus of the patient and the work we've done in relationship to a new procedure, which I'll describe shortly, varies between 4 to 13 centimetres. Thus, there are patients, and we are all aware of this, colorectal surgeons, that if you do a pelvic pouch operation, you can in fact leave 10 to 12 centimetres of distal rectum, and in fact what you're doing is a pouch rectal anastomosis, and that happens from time to time, and I have actually operated on people like that with residual disease in the rectal stump. But it's where you feel you can't go any further that I think this rectal no man's land can be exploited. So this is the rectal no man's land exploited, if you like, by what I call the appear technique. You will see during this lecture lots of acronyms. I like the appear technique. The appear technique, appear stands for anterior perineal plane, for ultra-low anterior resection of the rectum. Appear, the anatomy appears before you. And I think this is a good acronym. Some acronyms are crass. I think this is a very good one. I would say that, of course. So here you are. This is the anterior perineal plane. That's the rectal no man's land. It's been opened up between the puborectalis. You can see the puborectalis there and the rectum there. And this, you will never see a better picture of the distal mesorectum. You can see the buttocks, as it were, that Bill Heald always talks about, and how you can remove the whole of the mesorectum through this approach. The next picture shows the whole rectum everted through the perineum. And again, I defy anyone to see a better picture of the sphincter. That is the anal sphincter. That is the external anal sphincter in total. So the tumour in this particular patient is there, and you can see how clear view you can get of that pathology, and you can cross-staple and you can do an anastomosis through here. And that's the sphincter, that's the colon brought down to do the anastomosis. That, ladies and gentlemen, is the appear procedure. Doing this in recent years, we've shown that of patients who would otherwise require a permanent stoma, we've managed to preserve the sphincter and their continence, as you can see, in 70%, have avoided a stoma. And up to now, and we've been going for 5 or 6 years now, without evidence to date of a detriment to outcome. No excess local recurrence. Now, John Hunter, you will recall, made this wonderful statement that a lot of surgery was the axe of the armed savage who attempts to get that by force, which a civilized man would get by stratagem. I put it to you that an abdominoperineal excision with a permanent stoma is the act of an armed savage. And in this day and age, we should be avoiding that. As you can see, this is a patient who's had a laparoscopic appear procedure. Patient on the right is one that John McPhee performed earlier. That's a joke. He didn't really. Now, a lesson. I wanted to tell you all about the lessons that I've learnt and impart some of these to you, particularly the younger people. I thought we were the only people in the world that had thought of the anterior perineal approach for this sort of work. And we were very chuffed. And I think we actually wrote it in a paper. And precedence, as you can see, is defined as priority in time and order. So you can imagine my real upset when I got a letter from a Frenchman informing me that we were not the first group to ever perform it. This was, in fact, performed first in 1903 and repeated by Bricot in 1963, who did about 60 cases like this, but then retired, and it wasn't taken up any further. So, a lesson learnt. There is virtually, anyway, nothing new under the sun. Going on, there are times, of course, where you have to remove the sphincter. So we had thought long and hard about how could you replace the sphincter, and we came up with this concept of electrically stimulating the gracilis muscle to create a neo-sphincter. And you can see from this, I like showing this slide. As somebody remarked, it's like cracking nuts. You see how the sphincter the gracilis can be stimulated to produce a neo-sphincter. And I can't move on. This could be very tedious. And the anus winking at you for the rest of the lecture. I do apologize, I just cannot move this forward. Okay. So this concept of electrically stimulated neo-sphincter was predicated on a basic scientific principle that you could convert fast twitch type 2 fatigable muscle to slow twitch type 1 non-fatigable muscle that was a sphincter in essence. And we were able, this was a beautiful paper that Bruce George actually won the Moynihan Prize on, showing exactly this. You can see that the type 1 muscle fibers here being converted totally, the muscle completely converted into slow twitch muscle, as you can see in this slide. And we showed in our first studies, this is a paper that James Mander got published in the BJS, and you can see here that 77% of patients had a good functional result. These were patients who had virtually no sphincter whatsoever or had been totally reconstructed. And we were very, very pleased with that. However, I decided that we ought to evaluate these patients by a third party. I think this is the best way of determining, as you will see, how good you really are. So we got a grant and we conducted this, and this is an epidemiologist, Professor Feldman, and Therese Tillin, who actually did most of the work. And they actually looked at our patients and published this paper, which is a third-party prospective evaluation of this particular operation. Quite a complex set of analysis, different modalities. And they concluded that the results indicate less favorable outcomes than previously reported in clinician-conducted studies. And that was not just ourselves, but others as well. So we had reported a 74% improvement success rate, if you like, and glibly you reported this all over the world. But when Therese and Richard looked harder, you could see that half of those with a satisfactory continence outcome had ongoing evacuatory difficulties and worsening pain. So another lesson, or several lessons learned after that particular procedure. And the lessons are, you should assume that the surgical group who developed the procedure is biased. And objectivity, in my view, is essential. And assessment should be holistic. You shouldn't just look at one. We looked at one modality, and that was continence, whereas we should have looked at quality of life and various other factors. And quality of life outcomes are much more complex than you would think. And you must learn, you must never assume that what you do is wonderful. And any innovation you do has to be fantastic. You must always step back and accept the criticism. Otherwise, you'll never move it forward. And we did look at that, and we learned that the problem there was that there was a difficulty in patients evacuating. And in fact, when we looked at these patients, some of them required to have an ACE procedure. We used a colonic conduit here, but it's the same principle. You create a small opening into the colon, into the rectum, so the patient can evacuate and irrigate in a distal direction. And we showed also that you could combine this in a patient with total, who needed a total anorectal reconstruction post APER, etc. And particularly in the younger patient who'd had born with anorectal agenesis. And appreciate this is complex surgery and it may not be suitable for everybody, but quite a few patients want to go that extra mile to avoid a stoma or be reversed in some way. So that combination is a way of proceeding. Moving on, another area I've always had an interest in is patients who have severe incontinence. And this group of patients who have failed all other forms of therapy can be very distressed. Nowadays we use sacral nerve stimulation more and more, but at that time that was just coming in. So based on physiological selection, low rectal compliance, hypersensitive, high amplitude motor waves in the rectum, we devised a procedure based on those physiological parameters and selected, which we called rectal augmentation. And this really utilized the distal ileum, the segment of the distal ileum that was then stapled onto the front of the rectum in this highly selected group of patients to augment the rectum, to increase its compliance and increase its volume and reduce the urgency. And here is an ambulatory motility slide showing over time. You can see these huge generated waves in the rectum, huge, 200 millimeters of mercury. That's a really quite a high pressure. And you can see here post-augmentation how you could reduce those waves that are associated with the incontinence. And we showed that compliance could be increased. Patients could defer rectal evacuation. So that was one group of patients with a functional abnormality. This is another difficult area, megarectum. These are patients who can't evacuate. And you can see here the size of the rectum. This is a patient of mine. Huge distension, megarectum. Real problem. Is it congenital? Is it functional entirely? We don't really know. People have tried to resect the rectum. You can imagine trying to resect the whole rectum here. These are huge veins. And I've seen and heard of patients dying as a result of operative trauma in those patients with megarectum. So we came up with the alternative. This is akin, if you like, to the urologists, because the urologists do this for megabladders. And we did the same, resecting the dilated sigmoid colon, resecting the anterior half of the rectum, and call this vertical reduction rectoplexic. And showed, again, physiologically, that we could improve. You don't need to look at all this data, but it just shows the physiological measurements of this operation showing improvement. And rectal compliance, as you can see, improving. And very importantly, of course, they were clinically improved. And we were able to show, it's no good showing things immediately after surgery. You have to follow up patients appropriately, and the medium-term results also showing that to be the case. So these two operations devised to try and sort out physiological problems also gave us the fantastic opportunity for what we call reverse translation, which is really taking an operation, obtaining tissue that you couldn't obtain before, and doing scientific analysis on that, which you couldn't possibly do at any other time. And in the rectal augmentation operation, we were able to take full thickness rectal wall, which no other group could have done, showing the benefits of surgical research. And we were able, Chris Chan, in this wonderful paper published in The Lancet, showed that in the wall of these patients with rectal hypersensitivity, they had an upregulation of TRPV1. That's the capsaicin receptor. That's when you have a curry and you visit the toilet frequently, as I'm sure many of you know, that is the chili receptor. And we were able to show how upregulated it is. And also now GSK are working on this receptor to produce drugs which can actually block it. So we shouldn't have to have operations for these sort of patients in the future if they come up with a success. But it's that sort of data that provided that answer. So reverse translation, absolutely key. Another area, the opposite, obstructive defecation, And here is the classical rectal intussusception, often thought to be a cause of the problem, often associated, well, if left for a substantial period of time, with a full-thickness rectal prolapse, and often associated, as you can see, with a rectocele. But is this cause or effect? Is it chicken or egg? We looked at this and thought, well, these prolapses, these internal intussusceptions often come from the anterior rectal wall. Can we produce an operation which can deal with that anatomical abnormality? Another acronym for you, external pelvic rectal suspension, the EXPRESS procedure. I quite like that acronym, that's not a bad one. The scientific principle we applied here, of course, is correction of the anatomical abnormality is perceived to be the cause of the function problem, and it will correct it. Well, that's the operation. I'm to go through quickly, but it's basically putting some form of mesh, in this case collagen mesh, anteriorly, as you can see here, and pulling it up and suturing it to the pubic tuberosities on either side, and at the same time repairing the rectocele. And you can see here how you can actually correct the anatomical abnormality. Here's the intussusception, here's the rectocele. Post-operatively, it's virtually gone. So we knew that we could do that. And in fact, we also showed there was some improvement in function. And this is a GI quality of life index. This has been taken on by our laparoscopically, and now people are doing this laparoscopically, and that's fine. They're doing hundreds and hundreds of these operations. If we go on to think about this a bit more, though, it's not just an anatomical abnormality. It's a very, very complex rectal evacuation difficulties, an extremely complex area. They involve a lot of physiological mechanisms. They involve the psychosocial and behavioral problems. It's complex, and it's naive to think that restoring anything anatomically like we did would work. And sadly, there are certain groups around the world, actually, correcting this abnormality, often for the wrong reasons. And you'll note here that we've only done 1% of the patients referred to us have been treated operatively. So we've been highly, highly selective because it's a complex business. So lessons learned. Corrections of anatomical abnormalities are not always successful in complex multifactorial functional problems, and selection of patients is key. A fool with a tool, i.e. an operation, is still a fool. I think that's a very good aphorism to remember. So, back to my uncle. Here he is, Shim, great man, with his colostomy. And this is why he and I feel that it's important to retain the sphincter. And some of you have seen this before, but I'm going to read it because it's so good. It just basically says it all. They say that man has succeeded where the animals fail because of the clever use of his hands. Yet when compared to the hands, the sphincter ani is far superior. If you place into your cupped hands a mixture of fluid, solid, and gas, and then through an opening at the bottom, try and let only the gas escape, you will fail. Yet the sphincter ani can do it. The sphincter apparently can differentiate between solid, fluid, and gas. It apparently can tell whether its owner is alone or with someone, whether standing or sitting, whether its owner has his pants on or off. No other muscle in the body is such a protector of the dignity of man, yet so ready to come to his relief. A muscle like this is worth protecting. And I can see you agree. You're all sat there contracting away. So, to return to my uncle, we all know that certain patients will require colostomies. That's my case on the left, on your right, and of course that's John McPhee's on the right, on the other side. The peristomal hernia. Nobody should have peristomal hernia. Immense problems. Everybody who's seen, we don't see as many as there are because the stoma care nurses look after them. They're amazing problems, often very difficult, not just the cosmesis, but leads to obstruction and all sorts of difficulties. The incidence is huge. I don't know how many colorectal surgeons or patients who tell their patients that they've got a 50% chance of getting a peristomal hernia, and a third of those will require a repair. And the repairs are awful. They don't work very often unless you take it to the other side, and even taking it to the other side will cause a problem. John Gallagher, who was a mentor of some of us in Leeds, who wrote that fantastic colorectal book, Surgery of the Anus, Colon, and Rectum, said some degree of herniation around a stoma is so common that this complication may be regarded as inevitable. Well, John Gallagher, I regard that as a touch of the arm savage about conventional stoma trephine formation. Those are two fingers, and those two fingers will vary, and the degree of stretch that you put on that. How crude is that? How crude is that? You're setting yourself up or the patient up to get a peristomal hernia. It's not great, is it, in this modern age that we use such an imprecise method of stoma formation. And I find that John Gallagher, who I had tremendous respect for, don't get me wrong, but I do find that sort of statement defeatist and nowadays totally unacceptable. So a lesson learned. Don't always accept, includes me this, what your mentor says as being gospel. So I asked the question in 2003, can mesh reinforcement of the stoma trephine prevent peristomal herniation? And we worked on this, and we used a mesh reinforcement as a prophylaxis in a sublay situation, and that's beneath the peritoneum. You can see the bowel going through here, and the mesh is underneath, surrounding and strengthening, one would hope, the trephine. And we set up a trial, the prophecy trial, and that's what it stands for, to look and randomize patients to this. So that was a prospective randomized controlled trial, as we all should be doing as much as we can. And we reckoned that the power for this study, you should have 320 patients in. And we set up this multi-center study, and we had 12 centers. And we thought we'd be finished in about 2 years. Well, 4 years later, we'd randomized 70 patients. Naive, you might think. So why was recruitment so poor when in the UK approximately 15,000 patients undergo stoma formation per year? Well, I thought this might be due to the Linda factor. Now, you'll be thinking, who the hell's Linda? Linda is my wife. She's a lovely woman, long-suffering. She bought me this TV set because she knows I like watching Sky Sports. Any sport, I'll watch it. She knows that. And she's very good to me. So one Christmas, she bought me this. And I was watching this, and I was thinking about this problem, a major problem. How do we get more patients into this prophecy trial? And I went round the back. And the answer, I thought, well, maybe there was no infrastructure. And that's often the problem. There isn't sufficient infrastructure. But I have to say, in the prophecy study, that wasn't the case. We had 12 centers. The surgeons were all in equipoise about this. They wanted to do the study. We had funding for research nurses, and we even had an external company to collect the data, and we had an independent data monitoring group. So why was it, in a relatively simple study, we couldn't recruit in the way we wanted? Well, the answer, in fact, was clear, although not as simple as this GCSE candidate thought. I think that's a wonderful slide. So what was the answer? Well, the answer was that the procedure that we were using was very cumbersome. Although it was simple, it was cumbersome. And at the end of an often arduous operation, surgeons hoped and prayed they'd not draw the test arm. And of course, we were moving as well to laparoscopic surgery. So we had to think about how to change things. And if you are going to innovate, and everybody in this room has the capacity to innovate, you mustn't be honed, you mustn't keep your mind along one track. You must learn from what you've done, what mistakes you've done, and you must be prepared, unlike some people, to be prepared to turn. I accept the fact that sometimes you shouldn't turn, but in innovation, you should be prepared to turn. The solution, in my view, was that we needed to devise a quicker, simpler, and precise procedure that could be performed at both open and laparoscopic surgery. So we came up with another acronym, Staple mesh stoma reinforcement technique. Now, this one I really like. This is a SMART procedure. And the SMART, if we can get this going, just show you.
SMART can be utilized either in open or laparoscopic surgery for stoma reinforcement. Either approach commences with the trephine formation in the standard way by excising a cylinder of abdominal wall skin and subcutaneous fat down to the anterior rectus sheath. The sheath is then opened with a cruciate incision. Next, the rectus muscle is split in the line of its fibers and gently retracted. Only the posterior rectus sheath and the peritoneum remain between the operator and the abdominal cavity here. The purpose-designed trocar-tipped anvil shaft grasper is then inserted via the abdominal wall trephine. Whilst carefully protecting the contents of the abdominal cavity, the two remaining layers are penetrated. The grasper tip is sufficiently sharp for that purpose, but blunted enough in order to reduce the chances of accidental tissue damage. The anvil of an appropriate size CS compact circular stapling gun is then introduced via the open abdomen. Once the anvil shaft has been grasped, the anvil is then exteriorized through the trephine to emerge on the abdominal wall. The purpose-designed angled grasper is used externally to steady the anvil shaft. The trocar of the stapling gun, which was previously loaded with a circular mesh, is now mated with the anvil shaft before the gun is closed. The gun is then fired and removed, leaving a precise reinforced staple trephine. The circumference of the mesh is next sutured to the anterior rectus sheath, so it lies flat against the anterior sheath and lines the trephine through the split muscle fibers. The colon or ilium is then drawn through the trephine and the stoma is fashioned in the usual way. SMART, when used in a laparoscopic approach, only differentiates in the way of introducing the anvil shaft into the abdominal cavity. If a separate abdominal wall incision has been created for specimen retrieval, the anvil shaft can be inserted in the same way as for the open technique. If this is not the case, a small incision is made via the abdominal wall trephine in the posterior rectus sheath and peritoneum, and a circular purse string suture is inserted into the edge of the incision. The anvil head is passed through this incision and the purse string is tied firmly on the shaft. The pneumoperitoneum is recreated. Before firing the gun, it is important to check with the laparoscopic camera that no bowel loops are trapped between the anvil and the posterior rectus sheath and peritoneum. From that point, the procedure then follows exactly the one described for open surgery.
So,
SMART.
I'm pleased to say now we've got a much simpler technique, which I think is more elegant and more precise, that we're randomizing at a much faster rate, and we've already got 50 patients in that trial after 9 months. So lessons learned, generally. Acronyms are de rigueur. You've got to come up with some nice Peer Express SMART. Wonderful, that's quite important. But seriously though, innovation is the lifeblood of surgery. We can't progress unless we innovate. And everyone in this room has that potential. And surgery is unique insofar as it can do things in science that other groups cannot do. Reverse translation. Precedence is an important factor, but don't become obsessed with it. You'll only get disappointed. Objectivity is essential. I think we should be doing more third-party assessments of the work that we do and what we innovate. And surgical innovation does depend quite a lot on physical science, applied physical science. And although I'm a great believer, I'm a member of the Genome Strategy Board of the NHS, that genes are important and a lot's going to come from that, we can't ignore physiology, anatomical studies, etc., and biochemical. We need a national structure, in my view, for safe development and diffusion of techniques. And I've got an aphorism that you need to protect the patient, but you also need to nurture the innovator and support them. Obviously, regulation and bureaucracy must be much better than it is at the moment. And I think people have got to realize that surgical techniques, they're not drugs. You can't do a dose-response curve on a sphincter-saving procedure. And I think that needs to be driven home time and time again. And industry plays a very important part in advancement, but it can't lead. The clinicians should lead it, not the companies, because so often techniques, widgets are produced and they're used inappropriately. And a multidisciplinary team obviously is essential. That's part of our multidisciplinary team, not the whole part, but it just shows you that you need a large team. And an innovator must never be discouraged by setbacks. You're going to have setbacks, but you've always got to remain optimistic. You know, you get headlines like this from time to time when you're innovating. I can assure you I wasn't taken by aliens. This is a wonderful story. This is Barry Marshall, who got the Nobel Prize with Robin Warren for Helicobacter, discovery of Helicobacter and its association with peptic ulcer. I went to a talk by him years ago, and he showed this slide, this next slide. This was and I actually took this during the lecture. You can see that his first research paper wasn't accepted by the Australian Gastroenterology Association. The number of abstracts we received continues to increase, and for this meeting, 67 were submitted, and we could only accept 56. So his paper, his Nobel Prize winning paper. So if you get a knockback by the ASGBI, don't worry, you may still win the Nobel Prize. And finally, another lesson. So we've developed this innovation centre, and national centre we like to call it, for bowel disease. And you might recognise that lady in the picture. And that's Charlie Knowles, my colleague, watching her sign our book, because they came just recently. She came with the Duke of Edinburgh to open the centre. And it was a fantastic day. And here I am, leading Her Majesty out of the centre back to a car. You'll note, and this is important to note, that my arm is here. I swear I didn't touch her. I swear to this day I didn't touch her. Because the next day, that's what happened. So, and the final lesson is make bloody sure you don't touch royalty. Thank you very much indeed.